I would like to welcome you to tonight's webinar entitled Cross-Cultural Issues in Patient-Provider Encounters. And our featured speaker is Toyosi Adike. Dr. Toyosi Adike is the Director of Cultural Competency of the Cultural Competency Program at the National Center for Primary Care. Dr. Adike combines his clinical and public health background in research in cultural competency with the National Center for Primary Care. He is a 2010-2011 Sexual Health Policy Leadership Fellow and faculty in the Department of Community Health and Preventive Medicine. His current research focuses on establishing a direct relationship between improved provider cultural competency and patient health outcomes. This presentation is approved for CE. Application for CME credit has been filed with the American Academy of Family Physicians and is approved for 1 hour of CME. Questions and comments can be submitted to the presenter throughout the presentation. To submit a question to the presenter, please type your question in the box provided and click the submit button. Questions, please, are welcomed. And in addition, there will be an extended question and answer session at the end of the presentation. So please join me for a warm welcoming of Dr. Adike.
Thank you very much, Mr. Gooding. Hello, everyone, and it's good to be here tonight.
Dr. Adike?
Yes. Hello? Can you hear me?
Yes, you're on.
Okay.
Go ahead.
I'll just start by reading the disclosure statement. In compliance with the American Academy of Family Physicians guidelines, I hereby declare I do not have any financial or other relationships with the manufacturers of any commercial services discussed in this educational activity. Tonight, I'd like us to discuss cross-cultural issues in patient-provider encounters. This topic is really important because it's clicking so fast. Okay, it's really important because it is projected that by the year 2050, the United States, ethnic minority groups in the United States will consist half of the US population. America is definitely becoming very diverse, and with this diversity comes different people with different ideas and different beliefs, different value systems, and as we can see, for healthcare providers, our jobs are cut out for us. It is our responsibility to accommodate and cater effectively for everyone regardless of their cultural backgrounds. And there is no better way to learn this than through cultural competency training. Let's start from the basics. Culture. Culture can be defined as the way people think, communicate, act, their customs, beliefs, their value systems, and institutions of race, ethnicity, religion, and social groups. Now, when we think about culture, we think about the core aspects that culture consists of, and this includes race, ethnicity, history, religion, national origin, and so on. Now, if you look at this core components as they're expressed through an individual, other factors come into play, including gender, age, family dynamics, and personal psychology. Still going forward, culture expressed through individuals over a period of time is when you have determination of sexual orientation, acquisition of social status and power, education and profession, acculturation. This list of factors that culture consists of is by far not exhausted, but this is just like a summary to give us an idea of what we'll be discussing tonight. What exactly is cultural competence? It is just the idea of effectively operating in different cultural contexts and altering our practices or tailoring our practices to suit our patients from diverse backgrounds. In thinking about this, I'd like us to consider culture and healthcare. Expressions of culture in healthcare is based on our cultural health belief systems. And this is what helps us in determining or defining and categorizing health and illness. Is what is the basis for the explanations we have for the models of health or illness we have. It's also the basis for the theories we propose for relationship between cause and nature of illness. It is also what defines the specific scope of practice for healthcare providers in all cultures. Let's think about the culture of Western medicine. It's a culture where we know we have to make it better for the patient, improving quality of life and longevity. We intervene, we're dominant, we try to be dominant over nature, we try to take control. We're proactive as opposed to just waiting for nature to take its course in most cases. We believe in acting quickly, sooner than later. We are aggressive therapeutically, using multiple models of therapy or multiple therapeutic agents to fight the same illness sometimes. And then we plan and try to improve on what we currently have every day. We also operate on a standard, meaning that we treat similar cases in the same manner. Now I'm going to compare this a little bit with culture and healthcare in other cultures. Now I've tagged these other cultures because I'm trying to avoid any kind of stereotyping of a particular culture. So this is just a summary, a general summary of things that occur in some other cultures as pertains to healthcare. While in the culture of Western medicine, we try to improve the health of our patients, some people accept with grace, accepting that it's the will of a supernatural being and nature should take its course. We try to exert control over nature, while some people try to balance or harmonize with nature. We're very proactive, and like I mentioned earlier, some people wait and see what happens and allow nature take its course. We intervene as soon as possible, while others deliberate cautiously. We intervene with very strong measures, while some other cultures believe in a gentle approach. We plan ahead, we improve on what we do. That's why we do research and we improve on our science. Some people take life as it comes. We operate on a standard and treat everyone the same or similar cases in the same manner, while others individualize their cases, recognizing differences in patients. For example, in some cultures, a patient presents with a fever and a healer will give a teaspoon of some kind of substance. The next day, someone else presents with the same kind of fever, and the same healer gives the person 2 cups of the same substance. So the treatment is mostly individualized. What I'm trying to depict here is that cultures in healthcare exist in different dimensions. Western culture does exist, and there are other cultures that we have to recognize, try to understand. Even if we think it's not the right way to go about it, we need to recognize it, understand, and try to respect it. In the National Center for Primary Care, we have multiple tools that we use for our workshops in training on cultural competency. CRASH is one of them and has been presented at this webinar in the past. Today, I'm going to step a little bit outside that, talking about some of the multiple layers of culture that we need to understand so we can cater for our patients effectively. A very important cross-cultural issue in patient-provider encounter is religion. It is important to understand and respect religious norms and values of our patients to ensure and to build that trust that will lead to better medication and treatment compliance. Let's take an example of medication. For example, some of our pharmaceuticals contain gelatin bases that are gotten from animals. In some religions, these animals are sacred or are forbidden. For example, in Islam, it is forbidden to eat pork, and some gelatin can be gotten from pork that is used in making these medications. Another example is Hindus, who have the cow as a sacred animal, and as such, a lot of Hindus are either vegetarians or vegans and do not usually eat animal products. And so, if alternatives exist, it is important to explain this to the patient and possibly think about providing such alternatives to the patient. Now, this all depends on, like I had mentioned earlier, multiple layers of culture, including acculturation. Some acculturation and how deep the individual is in that religion. Sometimes you have Muslims who eat pork. It is in Islam, it is forbidden to do that. But at some point, level of acculturation and how deep they are in the religion also play a role. So this by no means should allow any healthcare provider stereotype and think, since a person is a Muslim, I will have to provide an alternative medication. It's important to discuss this with the patient. We think about diet. When sometimes we discuss diet with our patients, it's important to ask the components in their culture that may affect the kind of diet we will try to advise them to take. Another situation where diet plays a big role in religion is in Islam. In the ninth month of the Islamic calendar, there is the Ramadan, which is the fasting month. It's 30 days of fasting, or thereabout. And within this period, a lot of patients have a situation where they're caught between fasting, that is total fasting, no food or drink, and taking medications when they're ill. I must mention at this point that Islam provides that an individual who has a health issue can be allowed to take medications during this period. But all this depends on the individual. Many healthcare providers have seen situations where patients will refuse to take medications because of fasting. And you have to think about diabetic patients on insulin and things like that. Another important aspect of religion that I think it's something that can be a big issue in patient-provider encounters is communication and interaction. It is important for providers to understand verbal and nonverbal cues, to realize that certain religions allow for certain things and frown at other things. An example is in interacting with a Muslim of opposite sex, it is inappropriate and unacceptable to extend a handshake. It is better for a healthcare provider to wait for the patient of an opposite sex to extend the hand for a handshake before and then respectfully accept it. This is important because sometimes if doctors are unaware of some of these religious issues and you extend a handshake, you've already breached some kind of respect and trust that the patient requires. Another important aspect to consider in some cultures or some religions too, it is important for a female patient to see a physician, especially a male physician, and to be accompanied by a male member of the family. And that male member does not necessarily have to be her husband or her father, just a male family representative. This might pose a situation for a doctor or a healthcare provider who feels he needs the person accompanying the patient needs to step out. So it's important to understand some of this to foster the trust between patient and providers. I'm going to play a short clip at this moment, and I would like you to listen to the options that will be presented at the end of this clip, and we can have a short discussion on this.
evening. I'm Dr. Lieberman. How are you doing tonight?
Oh, doctor.
Hey, I've got some really bad news for you. There's not a female doctor on call here tonight, so I'm going to have to examine your wife. It's very important. The baby's almost here, so...
You need to find Dr. Simmons.
No, you don't understand. She's not here. I'm going to have to examine your wife. It's getting very close.
So you don't understand. You will not be able to examine my wife. You must find her.
Look, I've tried everything. I've tried her on her beeper. I just can't find her. She must be out of town.
You must find Dr. Simmons.
Look, I've got to examine your wife. Your baby is coming. You want a healthy baby.
You're not touching my wife.
No, I understand. I will be very, very respectful. I've done this 100 times. I've delivered 100 babies. Time is critical right now. We've got to do all we can to keep your baby healthy. I've trained in the best hospitals in America.
Call the administrator.
No, you don't understand. Your wife, your baby.
Yes, my wife, my baby. My responsibility. You don't understand that.
No, I'm hearing you, and I respect everything that you're saying, but this baby is going to come whether you say so or not. We have got to take care of your wife. I must examine her. Don't you want a healthy wife and a healthy baby?
Please. We're leaving. Let's go. We're leaving.
Excuse me.
Let's go.
What would you do in this situation? A.
So I know that it was kind of freezing at some point. I want you to think of what we just saw now, and then listen to these options, and we can have a short discussion.
What would you do in this situation? A. Transfer the patient to another hospital 30 miles away, where a female OB resident is available to deliver the patient.
B. Do you let the labor and delivery nurse, an RN, not a midwife or nurse practitioner, deliver the baby with the male obstetrician giving instructions from behind a curtain?
C. Do you express empathy and regret that the hospital is unable to meet their needs, but insist that the male doctor is the only competent one to deliver her baby?
Or D. Do you diplomatically take the husband from the room and try to talk separately with the patient to see if she can make a decision that would help you out of this scenario?
Okay. So which of these options do you think is most appropriate in this situation?
Participants, you can enter your guests into the
With C. Okay, that's a nice idea. Okay, I see we have a couple of people that agree with C. Anybody else? Can I have that video right back? Thank you.
Yes, my wife, my baby.
What would you do in this situation?
A healthy wife and a healthy baby?
Please. We'll
A. Transfer the patient to another hospital 30 miles away, where a female OB resident is available to deliver the patient.
B. Do you let the labor and delivery nurse, an RN, not a midwife or nurse practitioner, deliver the baby with the male obstetrician giving instructions from behind a curtain?
C. Do you express empathy and regret that the hospital is unable to meet their needs, but insist that the male doctor is the only competent one to deliver her baby?
Or D. Do you diplomatically...
Okay, so I just played that again so that everybody else will hear what the option C is. And Dr. Travis has said that maybe B. Okay, so we see ideas floating back and forth. I'll have to say that all of this are options, fairly good options, but none of them is the best option in this situation. So we have a couple of B's and a couple of C's. Let's see what the final option is.
D. Do you diplomatically take the husband from the room and try to talk separately with the patient to see if she can make a decision that would help you out of this scenario?
Is anybody considering option D? maybe asked the male doctor should have asked the husband to step out for a minute, and then he should have tried talking to the husband, and maybe one of the nurses should have tried talking to the wife to help make an independent a decision. Any other ideas? So let's find out what the correct answer is in this situation.
None of these are good options. You should have talked to the patient and her husband early on in their prenatal care. Discuss what issues will be important for you at delivery. Discuss on-call arrangements so that they understand that the female obstetrician who's been caring for the patient may not be the one to be there at delivery. The baby will be born, one way or another, without or with the doctor's help. But in this situation, all, the doctor, the husband, the wife, and the baby, will suffer unnecessarily.
Thank you. So, just like we have discussed in the question and answer panel here, all the options are fair options that we can consider, but ideally, this is a patient whose needs should have been met. Well, at this point, what can be, based on experience, what has been done in these situations in the past is having a resident. If there's a resident or a midwife around that can help take the delivery, like somebody suggested in this panel. But ideally, we should not let things get to this point before we address the situation. We have a patient who, in this case, this patient's religion and her culture has not been put into total considerations before delivery. And when situations like this arise, we find out that the doctor-patient trust is broken, and subsequently they go into the communities and talk about how they were poorly treated in this hospital and dissuade others from coming or seeking medical help in the same facility. The ideal case is a situation where we have a patient, we consider all the layers of culture that can influence the treatment of this patient and address those before situations like this arise. Now, in this case, that the situation is this way, personally, I feel the doctor was kind of forceful. He did not try to reason with the husband. And if you noticed in this video, in this vignette, the wife was quiet throughout, which means the decision making is solely the responsibility of the husband. It is another cultural layer that has to be considered. The support network, the power dynamics in the family, and the decision makers. All of these people have to be put into consideration during the treatment of this patient and not at the last minute. This is an important lesson for people, for healthcare providers to understand, to recognize and understand, and to be cautious of in practice. I'm going to move on and talk a little bit about literacy and language. In many occasions, we find out we have a lot of patients who present with low health literacy. So what is health literacy? It's the degree to which individuals have the capacity to obtain, process, understand basic health information and services needed to make appropriate health decisions. We'll assume that everybody should be able to handle this, but unfortunately only 12% of adults have proficient health literacy in the United States, which comes to about 9 out of 10 adults may lack the skills needed to manage their health and prevent disease. About 14% of US adults have below basic health literacy. And what this means is that they are unable to read nutrition labels. They do not fully understand consent for procedures. They take their treatments incorrectly. And this is one of the reasons why in cultural competency we talk about using various methods to ensure that to assess the health literacy level of our patients, and to also determine how much they understand what we have told them. It is common practice for physicians, healthcare and other healthcare providers to give instructions and to follow those instructions by the question, do you understand? And 9 out of 10 times the response to that will be yes, regardless of if the patient truly understands the instructions or not. That is not the right way to do it. The most appropriate way and the most beneficial way for the patient is the teach back method. And this method involves, in the course of the treatment, asking the patient to repeat to the healthcare provider how he or she will take the medications prescribed at home. That way, corrections can be made to any mistakes the patient might make at home. I know because of time constriction, it might be a bit difficult to have a patient to assess, to totally assess the health literacy level of a patient. But simple procedures like this can improve the impact of a short encounter and also the health outcomes in these patients. Language is a very important aspect, and inability to communicate with a healthcare provider creates one of the largest or the biggest healthcare barriers. Lack of a common language can result in misdiagnosis, misunderstanding, and inappropriate treatment. Now, talking about language, in the course of this training over the years, we found out that a whole lot of healthcare providers believe that once they can speak a language, the language of the patient, it is just as good as being culturally competent. That is far from the truth. It is a first step. It is a big step, but it's a first step. And this step, for those who cannot speak the same language as their patients, can be overcome by the use of professionally trained medical interpreters. I know there is a lack of medical interpreters in the US who are professionally trained, and sometimes, especially in the past, people had used family members and children to interpret for patients. This poses a big issue. For example, in a situation where you have a child acting as an interpreter for a parent, the child may decide to hide certain information they find embarrassing from the physician. Instead of interpreting the whole statement the parent makes, the child selectively chooses certain things. And also, the patient, the child can also find it very uncomfortable to give certain diagnoses to the patient who may be a parent. So that is a no-no. And the use of family members, just the same thing too. The discomfort and the shift in power dynamics is a big problem that has to be avoided. And in using a medical interpreter, it is important to use the interpreter at the beginning of the encounter. In the course of this training, I will once again mention that we have come across situations where a doctor who, for example, speaks a little Spanish and has a Spanish-speaking patient, starts the encounter in Spanish and finds out that he's experiencing language difficulties. And somewhere in the middle of this encounter, he now is frustrated, the patient is upset, and then it's at that point the healthcare provider requests an interpreter to come in. To better foster a good relationship and trust between the patient and the provider, it is important to ask the patient from the onset what language they would rather have the interview or the encounter, and if it's in any other language that the physician is not proficient in, an interpreter should be brought in immediately. Language does not only play a role when it comes to direct interaction with the patient. In situations where there's indirect communication or communication with other members in the other hospital staff and patients over here, it can also pose a big problem. I'll show you a brief example of that shortly. Can I have the second video? Let's watch this and we'll have a quick discussion about this too.
Hey, John. Busy morning. I heard you saw 17 patients.
Yeah, I've been kind of busy. I've seen a few flu cases and a few rashes.
Oh, you're so modest. You know you'll get that productivity bonus again this month.
Yeah, I guess, but let's not forget our quality program, which is focusing this month on cancer. Cancer screening is very important. Prostate cancer and especially colorectal cancer. You know how it is. When patients come in with all the problems, you tend to forget. And male patients don't like us poking around.
But remember, it's not just men. Women are having pap smears and mammograms. But we're not sticking our fingers up enough rectums, you know.
Okay, now let me get back to my patient.
Okay. But don't forget, today the big word is cancer.
Okay.
But remember, when you see Mr. Lopez, prostate cancer screening.
Okay. Let me get back to my patient.
And get that finger in that rectum. Remember, cancer.
¿Cómo estás? Muy bien, perfecto. No necesito nada.
Later that evening, Mrs. Lopez asks her husband if anything is wrong. He seems worried. He says he's fine, but she knows he is worried. It takes a few days, but finally he tells her, "The doctors think I have cancer." Whether it's a staff speaking Spanish in front of English-only colleagues, or English-only staff speaking in front of Spanish-speaking patients, the issues are similar.
What went wrong here? The issues are similar, whether you have Spanish-speaking staff speaking Spanish in front of...
Okay, it was phrasing a little bit on my end. I really don't like the look on the man's face, on the patient's face. Now, this is a situation where you have a doctor who speaks the same language as the patient. He's probably bilingual because he was speaking English, but now he's communicating directly with the patient in Spanish. In this situation, what are your thoughts? Anybody? This kind of encounter, this kind of situation could occur with other hospital staff, not necessarily. Thank you. It definitely shouldn't have taken place in front of the patient. So in this situation, this conversation has happened. The patient apparently speaks only Spanish and understands a few words in English. And the words that struck him was just cancer. And these are some of the things we need to consider as healthcare professionals. I think you've answered the question. You've just answered the question, and which someone just suggested that perhaps a follow-up with the patient to Dr. Travis to explain what happened if the provider noticed it is the ideal thing to do in this situation. But then what happens if this situation occurs between other hospital staff or clinic staff and they don't have direct access to the patient to explain what they were talking about? Any suggestions? Okay. In a situation like that, let's see what we could do about it.
No necesito nada. Later that evening, Mrs. Lopez asks her husband if anything is wrong. He seems worried. He says he's fine, but she knows he is worried. It takes a few days, but finally he tells her, "The doctors think I have cancer." Whether it's a staff speaking Spanish in front of English-only colleagues, or English-only staff speaking in front of Spanish-speaking patients, the issues are similar.
What went wrong here? The issues are similar, whether you have Spanish-speaking staff speaking Spanish in front of English-only speaking staff, or whether you have English-only staff speaking in front of Spanish-speaking patients. Misunderstanding is a possibility. What should you do? Acknowledge everyone within earshot. Explain why you're speaking whatever language you are, and carefully explain the background of what you were saying.
Okay. So, as has been suggested here, this conversation should never have happened in the first place. Sometimes these things happen and they have to be corrected immediately. In this situation, it was not, and it posed a big problem in this encounter. We're going to come back and have a little discussion on all these issues, but I'm going to move on at this moment and talk a little bit about sexual orientation, which is another layer of culture that we need to consider when we see our patients. We do know that as of today, there is really no federal or national database that gives an adequate or accurate number of people who identify as lesbian, gay, bisexual, or transgender. Some people are still in the closet, and some are openly identify as LGBT. Now, in this situation, how can we effectively cater for the needs of our patients who may or may not identify as LGBT? I've heard on first-hand basis from people who identify as LGBT that when they go to a clinic, some of the first things they scan around for is a sign that says that the environment is a safe, non-judgmental environment for LGBT patients. If that is not available, they scan around for resources or brochures on health issues that affect LGBT in the waiting area. That gives them an air or some kind of comfort that the doctors are aware of this population, and the doctors may be comfortable addressing the needs of this population. Now, this population is an important population that has to be catered to effectively. I'm not saying any other population is more important than the other, but the reason why this is a different layer of culture that has to be considered is because most times, if we have a patient from a different culture, it might be a little easier to identify them, either if they speak English from the accent, or from the name, or just by asking directly. But most of those things don't follow when it comes to the issues of sexual orientation, especially for those who are who haven't come out openly to identify as LGBT. And in that situation, there are barriers to effective communication. Now, some of the barriers to effective communication that prevent a culturally effective encounter between patient and provider include things like lack of awareness on the part of healthcare providers on the appropriate terms and language to use to address people who identify as LGBT. The terms that are used can either foster the trust or can, at that moment, form a barrier to whatever kind of communication is going to continue from that moment on. Sociocultural history is very important. Taking the history from these patients should be done in privacy. I know this is something that most people who are on this webinar tonight would think, well, that's a normal thing, you take it in. But like you saw on the last vignette, there are certain situations where there are oversights. And questions could be asked in front of family or in front of friends. And that will prevent the individual from coming out to say, I identify as LGBT. And those things happen. Same thing with taking a sexual history. It is important to be culturally competent in a manner that sexual history, regardless of how short or how casual it's taken, should be taken using open-ended questions. Like, do you have a significant other? As opposed to asking, are you married or do you have children? Suggesting a heterosexual patient. We do know that in the US today, quite a number of states allow same-sex marriages and adoption of children by same-sex, couple. So it's important to take a good history in a culturally non-judgmental environment, culturally effective and non-judgmental environment to help facilitate such encounters. Even though medical records are protected by federal and state privacy laws, from my interaction with people who identify as LGBT, a lot of them still worry about illegitimate access to these records. They worry about that, and I think it's something that's very important for a healthcare provider who has a patient who is self-identified as LGBT to mention and to allay their fears on how these records are protected, because this can deter the patient from giving appropriate or correct statements on their sexual orientation. Recently, I discussed with a friend of mine who mentioned an incident that occurred. Now, I'm going to give a summary of this incident just to show you that it's important for the healthcare providers themselves to be culturally competent, to be non-judgmental, and to train their staff, their clinic or practice staff, especially front desk staff, on how to accommodate LGBT patients. So this patient calls the hospital, the clinic, to make an appointment with this primary care physician. And the person at the front desk who was making the appointment determined, had a discussion and tried to put him on the schedule. At some point, he did mention he was transgender. And the front desk person said, well, you know you have to pay out of pocket. And he asked why. He was appalled by that and the person said, well, we don't handle transgender issues here. The funny thing about this whole thing is, well, it's not really funny, but I mean, the weird thing about it is he wasn't going there for any transgender issue. He was going for a medical reason, which was covered by his insurance. So training the front desk staff and other hospital or clinic personnel is very important, so that such mistakes, because immediately after that, he decided he wasn't going to see that primary care physician. And he was asking if I knew people or physicians who had a safe, non-judgmental environment where he could go. So these are just simple examples of situations that occur on a daily basis. And going back again to the terms, inappropriate terms used in describing people who belong to the LGBT population. Those are things that can really, really cause a breach in communication between the patient and the provider. It is important to be aware, regardless of if healthcare providers see a whole lot of LGBT self-identified patients or not. It is good to just be aware of the terms, the correct and appropriate terms to use in such situations, and language to use also. As a follow-up on some of the products of some of the tools we use at the National Center for Primary Care, we have the crash course in cultural competency. It is based on, CRASH actually stands for culture, respect, assess, affirm, sensitivity, self-awareness, and humility. And like I mentioned earlier, it is a model that has been presented on this same webinar a while back, but I'm still going to just give a quick summary of this model for those who missed that webinar. We discussed culture. Today we have talked a lot about culture, and we have discussed the different layers of culture. Using the crash model, one of the things, the most important aspects we consider is trying to peel off the layers in culture like an onion, considering every aspect: sexual orientation, the gender, the age of the patient, race, ethnicity, the educational level, health literacy, social, just all the individual layers of this culture are considered, and then we model our training to teach physicians and other healthcare providers how to tailor their services to suit various populations. Respect is a universal thing. Now, the show of respect is not what we in America consider as respect. We have our culture in America, and other people have their cultures. We have to consider their culture and what is determined to be respect in their own culture, and not what we consider as respect here, because what we consider might not necessarily go that way. In some of our trainings, we've discussed the abuse of the respect aspect, where we have patients who come and do not look the doctor in the eyes when the doctor is talking. They keep their heads down like this. And many times when we ask this question, a lot of physicians, maybe I should ask that question. If you have a patient who doesn't look you in the eyes, what thought comes to your mind? What do you think about that patient? Anybody? Be frank, just give me the first thing that comes to your mind when you have a patient from a different culture who comes and presents without looking you in the face and shy. Okay, that's one. Anybody else? Abuse, yes. Respect, okay. So in reality, all of this are correct. Some patients don't look at the physician in the eyes or the healthcare provider in the eyes because they're shy. Maybe a telltale sign that there's some kind of abuse going on. Eye contact is a possibility. So there are various things that occur that can lead a patient to keep their heads down or their eyes down and not look the physician in the eyes. One important thing I want us to consider today is that in some cultures, it is actually a sign of respect not to look at someone you definitely respect in the eyes. It's a way of deferring to that person. So it is not, they're not shy, and it's not that they're abused. It's just a cultural thing. In some African cultures, in some Asian cultures, it is disrespectful to look at someone you hold in high esteem in the eyes. Doctors anywhere in the world, or healers, healthcare providers, are looked at with a lot of respect and prestige. And as such, when patients come in, they tend to show that respect. That is something that should be considered in addressing such a patient. It shouldn't be considered as a disrespectful method or a disrespectful attitude. So all the options we have here are definitely correct, because you have patients who come with some of these issues. We assess. So in assessment, excuse me, we try to find out how much the patient understands about the illness that they have presented with. We also try to know the people who are involved in their care. It could be that's their family support or their social support system, the decision makers in the family. And we try to now sit down and discuss with them on how, the issues we have talked about today, some of the issues we have talked about today, what parts of their culture may affect the kind of treatment we're proposing, what kind of issues we need to consider when we're addressing them, how they would like to be called, and all those tiny issues are things we do in a very short period in trying to assess the patient. And then we affirm, if we're unsure of any aspect of the culture of the patient we're addressing, it is important for us to ask. At the National Center for Primary Care, we believe that the patient is the only expert in his or her own culture. So what the patient tells you of his or her own cultural experience is the final thing. There is no standard rule as saying all Asians behave in this way, or all Asian cultures have this in common. Yeah, there's some general things that can be considered, but generally there are subcultures within cultures. And so the patient is the expert in his or her own culture. Sensitivity. When we talk about sensitivity, we know there's specific hot button topics that it's important. That's why earlier I mentioned observing verbal and non-verbal cues, seeing that there are areas where the patient is uncomfortable and we have to address that respectfully, and addressing those things can help foster the relationship. We should also be self-aware, which also boils down to our biases. Everybody's got some kind of bias or the other, either an obvious bias or an unconscious bias about certain cultures and certain races. Some people have learned to overcome those biases. Others are still in the process. I think it's a lifelong learning process. Humility in our crash model talks about realizing that no one ever attains cultural competency. Cultural competency is a lifelong learning model. It's something we keep learning about every day, and so nobody is fully culturally competent. 1 hour cultural competency training does not make anybody culturally competent. Neither does 5 weeks of cultural competency training. So it's important for us to consider those aspects. So if we find and to learn from our mistakes, if we see that we have offended a patient in one way, we should be quick to recognize that. We should be quick to apologize and to rectify the situation. Like we saw in the video where the doctors were talking about cancer screening and the patient overheard the word cancer. It was important for that doctor to, like was suggested on the Q&A panel here, to quickly express his apologies to the patient and explain the conversation that was going on outside the door. So that way the patient feels a little bit more comfortable in doing that. Another thing we propose is the LEARN model. Here, LEARN stands for listening, explaining, acknowledging, recommending, and negotiating. We listen with sympathy and understand the patient's perception of the problem. Like we have mentioned, the multiple layers of cultural competency exist. So the fact that we are proactive and we think it's better to address this right now from a culture of Western medicine does not necessarily mean the patient understands that. A patient who has lived his or her whole life believing that you should wait for nature to take its course now stands in front of someone he's meeting for the first time who is asking him that you have to be admitted in the hospital today for this surgery or something like that. So these are very important issues we have to consider. Understand the patient's perception of the problem. We then explain our own perception of the problem. Then we acknowledge and discuss differences and similarities in both perceptions. At the end of all of this, we recommend treatment. There's the Western culture model, which is actually a shifting model at this moment, where the authoritarian method of recommending or of prescription or treatment, where the doctor gives orders. The best way to ensure a culturally effective encounter is to recommend treatment. And in recommending treatment, we also have to consider that a lot of people from diverse cultures use a lot of complementary alternative medicine. It is important for us to have a basic idea of what these medicines are. Some people come and talk about using vitamins that they got from their countries of origin. And these vitamins are just herbs and local things that have not really been standardized. So it's important to have an idea of some of these basic things while we're recommending treatment so that these things do not interact with the treatment we're recommending. And finally, to negotiate an agreement. Because the fact that we make a prescription for a patient does not necessarily mean the patient goes home and takes the medication. So it's important for us to agree on something, on a treatment, before the patient leaves the doctor's office. I know that we have had a very short period to discuss these few items, these few core factors that influence encounters in patient and patient-provider encounters, but I will at this point entertain questions and any comments we have about any of the video vignettes and anything we have seen or discussed today. Thank you. Any comments, additions, questions? Oh, okay. That's all right. I'm sure he'll get reconnected.
This is for our co-host Richard has dropped off.
Okay, I hope nobody else is. Okay, so any questions? Does that, I mean, I feel we have a lot of culturally competent people. All the questions I asked were answered correctly. Any questions or any comments about anything I talked about today or any of the videos we watched today? Okay, I got my own questions. How many of, okay, you're welcome. Okay, I think we have a question here now. Exactly. So I'm not sure if I think everybody sees the Q&A panel. So the question, or the comment here is, the individual culture of the client also matters, such as previous experience with the medical profession. I think that is exactly correct. While I was in North Carolina, I had the opportunity to work with multiple refugee communities. And in those communities, you could find out a doctor they preferred, or doctor's office they preferred as compared to others, or a hospital that they would rather go to than others, simply because of the experience of one patient in this population. So there's a lot that happens when patients see a physician and have an experience. Exactly. So this is in line with what I just mentioned. Dr. Travis mentions that he remembers someone whose parents died due to medical mistakes and has been very wary of his medical doctors. It is very true. So experiences people have with, or encounters they have. That's why it's important for us to make the encounters as effective and culturally acceptable as possible, just to foster the health outcomes of our patients and trust with those patients. I was going to ask one quick question. How many of our participants today ask their patients if they take any complementary or alternative medicines? You know, I once saw a study that said only about 14% of US physicians asked but this was a few years ago. I think things might have changed a little bit, but only 14% of US physicians asked their patients about complementary and alternative medicine use. This is very important, and it's something that we need to consider, because some of these complementary alternative medicines can affect or interact with the medications we prescribe for our patients. So I see nobody none of our participants asked that question. Well, it's food for thought. It's important to ask our patients if they take any vitamins, no matter how insignificant the vitamins seem to be, and to consider how those vitamins can interact with whatever treatment or medications we prescribe. Any other questions or comments? Oh, okay. Okay, that's great.
Not quite yet.
Oh, he's back on?
Richard is going to come back on.
Well, I want to thank all of you for participating in this webinar tonight. I hope you did learn something today, and I hope I kind of improved your knowledge on cultural competency, or at least increased your awareness of certain things that you did not know before tonight. Is Richard back on? Oh, okay. Okay. Welcome.
We can't hear him, but that's fine. I will just say this.
Okay.
Thank you for that insightful presentation.
You're very welcome.
I learned. That was awesome. I really appreciated those videos too. We do have Richard, are you on? We have a CE evaluation that's going to pop up right now in your browser. Email you certificates, CME certificate. Tomorrow we have a special primary care coffee shop. Introducing your patient to hospice and palliative.
Well, thank you very much.
You can go to primary care for all. That's going to do it for tonight. Thank you all.